Hey guys, Miss Hill here. Welcome to Individual Module 5.1, PowerPoint 1. Here are your learning outcomes. Let's get started. In Individual Module 5.1, we talk mainly about antepartum and the female reproductive cycle. So here you have a slide that depicts the female internal reproductive system for you. You can see the ovaries, a uterus, and some fallopian tubes on this slide. The ovaries produce mature gametes or sex cells, and those secrete hormones. As the egg or the oocyte matures inside of the ovary, it will actually rupture out from inside the ovary and enter the fallopian tube, which is where which is where it will meet a sperm, may be fertilized, and then will travel down the fallopian tube into the uterus and implant itself into the endometrium, which is the inside lining of the uterus. For that to happen, the situation has to be favorable. The hormones have to work together in a certain way to allow fertilization and implantation of that egg. So we have a couple of hormones that play a really big role in this process. One of them is estrogen. Estrogen is a female hormone. It prepares the uterine lining for possible pregnancy, and it participates in pregnancy if pregnancy happens to occur. Progesterone is also the other big hormone related to the female reproductive cycle. It continually prepares the endometrium for possible pregnancy, and it inhibits contraction of the uterus, and it also inhibits the development of any new follicles. So progesterone is kind of your pregnancy maintenance hormone, if you can see it sort of that way. Hormones are released in different places. The ovary releases estrogen, progesterone, and testosterone. We don't talk a lot about that one, but females do have testosterone as well, but we're focusing mainly on estrogen and progesterone. The ovary is sensitive to follicle stimulating hormone and luteinizing hormone. The uterus is sensitive to estrogen and progesterone. Okay, so the ovary will produce estrogen and progesterone and progesterone work on the uterus. Here's a slide that shows you the male internal reproductive system, just to go over that so that you know the different types of the male internal reproductive system. But we don't go into a lot of hormones related to the male. So this is a little chart that tells you where the hormones are released and what they work on. Okay, so this is the hypothalamic pituitary axis gonadal cycle. That's a big mouthful, I know, but basically what this tells you is how the hormones work to make the female reproductive cycle effective. Okay, so the hypothalamus, which we all know is in the brain, secretes a hormone called gonadotropin-releasing hormone. Now, gonadotropin-releasing hormone works on the anterior pituitary gland in your brain and tells that area of the brain to release LH and FSH, your luteinizing hormone and your follicle stimulating hormone. The luteinizing hormone is responsible for the final maturation of the follicle, and it helps that follicle become what it needs to be released into an egg, okay? The follicle stimulating hormone is responsible for the maturation of the ovarian follicle. Okay, so one of them is responsible for the whole process. FSH, follicle stimulating hormone, stimulates the follicles. The luteinizing hormone actually makes sure that that follicle matures to the final point. All right, so our anterior pituitary gland releases those two hormones, luteinizing hormone and follicle stimulating hormone. And remember what I said in the last slide, those two hormones work on the ovaries. So there you can see, as those two hormones work on the ovary, the ovary will produce estrogen and progesterone. And then those two hormones work on the uterus. This is all a negative feedback system. So depending on what is happening with the hormones, there is some negative feedback that happens over the majority of the reproductive cycle. And estrogen is the hormone that causes that negative feedback. It only causes the anterior pituitary gland not to make more gonadotropins, okay? And this only happens if the estrogen levels are high enough in the body to prevent that. So this happens towards the end of the second week of the female reproductive cycle. I know that's a lot, but we're going to go into a little bit more in the next slide. Okay, so here are a couple of charts that talk to you about the two female hormones, estrogen and progesterone. Okay, the female reproductive cycle consists of two cycles that occur at the same time. The female reproductive cycle produces ovulation, that's one of the cycles, and it produces menstruation, and that is a second cycle. So those two cycles make up the female reproductive cycle, and they happen at the same time. They work together depending on these two hormones. So here what you can see is that a follicle begins to develop. Look at your chart on the right-hand side of the screen. We have a follicle that begins to develop. And as this happens and it starts to mature, then eventually, once it reaches final maturation, which happens because of the luteinizing hormone, the ovaries release an egg. Now, if you look down towards the middle of that chart, luteinizing hormone is in green, and you see that big, huge spike with the luteinizing hormone as ovulation happens, okay? And then you see it drop back off. Now, if you look down to the bottom of that chart, you actually will see the uterine lining. This is supposed to represent the endometrial lining of the uterus. When we talked last week about menstrual cycles, we talked about menstrual cycles beginning on which day? Day 1. That is the very first day that a woman starts her period. So you can see from about day 1 to day 7 on the bottom of your chart, where we're looking at the menstrual cycle, there's a little bit of bleeding, okay? And now, as you look at the rest of that cycle from about day 8 until about day 28, you can see the uterine lining growing. It's getting nice and cushy, hoping that it might have the chance for a fertilized egg to be implanted there. And if you go up to the middle of this chart and look at progesterone, you can see progesterone is kind of high during this time. So progesterone helps our uterine lining become nice and cushy in response to an anticipated pregnancy. Again, I know this is a lot. You just have to listen to it again and again until you can sort of put all of the pieces together, okay? The chart on the left-hand side is just another way that it shows kind of what I've talked about on the right-hand side. Okay, again, these are a couple of extra pictures to help you sort of move through this cycle. Some of you may learn better from one photo than you do from the other. Focus on the one that helps you learn the best, okay? This is just the same thing, another photo. This talks about the menstrual cycle and where it falls in regards to the hormones that help prepare for pregnancy. You may also look over that one. Okay. Here we have another photo, a little larger than the one I just talked about earlier. So let's go over this one more time. All right. So the first thing that happens in the female reproductive cycle is that we have to have a release of follicle stimulating hormone, or FSH. And if you look at your chart, the green area is FSH. And you can see that it's high and pretty steady as the follicles start to develop in this photo. So we're developing follicles in preparation for ovulating, okay? These follicles, as they start to develop, release estrogen. Remember that we said estrogen is released from the ovaries. Where do follicles develop? Follicles develop inside the ovaries. So as these follicles develop, they secrete estrogen. Estrogen prepares the uterine lining for pregnancy. It helps it start to thicken up. Okay? So look at your blue area. That's estrogen. You can see a little spike in the estrogen as the follicles begin to develop in this chart. Okay? And now take a peek at where ovulation occurs, right in the middle of your picture. Okay? And what causes ovulation is the surge in luteinizing hormone. Luteinizing hormone is released in the anterior pituitary gland. Okay, so we have a big spike in luteinizing hormone, and then the egg is released and the female ovulates. Okay, just giving you a second to catch up. Now, we've had ovulation to happen, and during this time, you can see what is high. Follicle stimulating hormone is high, luteinizing hormone is high, and estrogen is high because estrogen is preparing that lining of the endometrium. Now, once an egg is released, what is left over is called the corpus luteum. And the corpus luteum is what develops and secretes progesterone. All right, so if you look on the right-hand side of your screen to this sort of little ball of tissue-looking stuff, that's your corpus luteum. It's what's left over after the egg is released, and that secretes progesterone. If you look up to the top of this chart, what hormone is high? The pink one, which is progesterone. Progesterone causes continued thickening of the endometrium. It prevents the uterus from contracting, and it inhibits the development of new follicles. Okay? Now, look down to the very bottom of this chart, and as we go through that ovulation cycle, make sure that you relate it down to the menstrual cycle, where it says day of cycle. If you look on day 14, and remember, we're talking about a 28-day cycle on average. Every female does not have a 28-day cycle exactly every time. But on day 14 is about whenever people ovulate. Okay, sorry, my emails are coming through here. All right. As estrogen and progesterone begin to fall during this cycle, a positive feedback occurs and allows the anterior pituitary gland to secrete more FSH and LH in order to begin another ovulation cycle. Okay? So as estrogen and progesterone are high, that causes the negative feedback system that we were talking about on the earlier slide and prevents the brain from releasing any more FSH and LH. And that makes sense, right? Because if we're at the end of a cycle where a pregnancy normally occurs, we don't want to have our body continually trying to develop follicles and release an egg. Okay? We are anticipating a pregnancy is going to happen during that time. So those hormones are high and prevent the body from starting another cycle over. Because remember what happens on day one of the menstrual cycle. On day one of the menstrual cycle, the woman sheds her endometrial lining. If we shed that endometrial lining before an egg can implant, then the woman would never get pregnant. I hope that makes sense. I know it's a lot. Okay, just a funny little picture to break up the monotony of this. Again, this is another picture. I've put a bunch of photos in here in regards to fertilization in the menstrual cycle so that you can choose the one that helps you learn the best and focus on that one. All right, moving on. Let's talk about menstrual dysfunctions and menopause. Here are your learning outcomes. Another picture of the uterus and the uterine tubes and the endometrium. And what did we say the endometrium is? That is the inside lining of the uterus. All right, menstrual dysfunctions. One of the most known menstrual dysfunctions is PMS. It is a physical and a psychological symptomatic problem that happens with menstruation. Usually it occurs sometimes before the period happens, somewhere from 3 to 14 days prior to the start of menses. Usually those symptoms are relieved during the onset of the menstrual cycle. And a really severe form of PMS is PMDD, or premenstrual dysphoric disorder. And this is actually the psychiatric label that's used for describing the most severe form of this problem. So the timing for this says before menses, 3 to 14 days before menses. That would be approximately day 15 to 28 of a 28-day cycle, just to give you a point of reference. So what are some physical symptoms related to PMS? Well, they include breast tenderness, fatigue, food cravings, dizziness, headaches, palpitations, acne, urticaria, which is itching, right? Itching and rash, backache, constipation, and nausea and vomiting. The psychological symptoms related to PMS are mood swings, irritability, depression, anxiety, anger, aggressiveness, and inability to concentrate. All right, so here's some more, and we've gone over a lot of these already. Breast discomfort, headache, low backache, bloating, fatigue, edema, dizziness, and palpitations, depression, irritability, mood swings, binge eating, crying spells, and anxiety. All of those are signs and symptoms of PMS. About 25 to 40% of women have experienced some form of PMS, and of those 25 to 40%, about 2 to 5% of those have experienced the premenstrual dysphoric disorder, or PMDD. So, PMS in the menstrual cycle, 7 to 10 days prior to the menstrual cycle, or the luteal phase. Now, your book actually says 3 to 14 days prior, like I have in the previous slide. So remember that. And when is the luteal phase? The luteal phase happens when progesterone and estrogen are high towards the end of the cycle. It happens after ovulation, and it disappears with the decrease of both of those. The PMS will disappear after the decrease of those high hormones, right? Estrogen and progesterone. Once they drop off and the cycle begins, symptoms of PMS should be relieved. So what's the pathophysiology of PMS? Well, we don't really know. There are some theoretical ideas that people have come up with that they believe cause PMS. They include hormonal imbalances, so related to the estrogen and progesterone being high, or the ratios of those. There are also increased prolactin levels and rising aldosterone levels during this time. And those two things can contribute to sodium retention, which will cause bloating, right? We all know that. So there's the hormonal imbalance theory. There's a nutritional imbalance theory that says stress, sugar, and caffeine all can contribute. People crave salt, so they eat lots of salt, then they get more sodium retention. They end up with edema and bloating. There is a prostaglandin excess theory, and this one takes into consideration some type of modified forms of unsaturated fatty acids that are synthesized in the cells and act as chemical messengers. You guys do not have to know the details of these. And then endorphin deficiency. There are decreased levels of monoamine oxidase, which is associated with depression. And there is also decreased serotonin, and that can cause mood swings. So there are all types of different theories related to why PMS happens, but nobody has one good one where we can point to it and say, yes, this is the cause. And it could be a combination of every one of these. So how do we manage it? Well, we want to teach our patients to decrease caffeine, no alcohol, low salt, high protein and low sugar diets help. We want to teach them how to control stress. Exercising with balanced rest helps pretty much everything. There are some different types of drugs that will help manage PMS. Lupron, Eligard, and Zoladex are all examples of GnRH agonists. Prostaglandin inhibitors such as ibuprofen, indomethacin, naproxen, those all help with cramping. NSAIDs, your tricyclic antidepressants like amitriptyline, SSRIs like Prozac, Zoloft, and Paxil, OCPs or oral contraceptive pills, so birth control pills. Diuretics can help with the bloating. And then there are also herbal remedies that some people use. Moving on. Dysmenorrhea is painful menstruation, and this is another menstrual disorder that we will talk about. There are two types of dysmenorrhea. We have primary and secondary. Primary dysmenorrhea is very prevalent among young girls, so adolescents, and there's no type of organic cause for this. It's usually seen in girls who have just begun their menses. Secondary dysmenorrhea has an organic cause, meaning there is something going on that's actually causing the dysmenorrhea. So there's some type of pelvic disease maybe. Fibroids, endometriosis, infections, all of those are secondary types of dysmenorrhea. Cancer could be one. So why does this happen? Well, there is an excessive production of prostaglandins that will stimulate uterine contractions, and if we stimulate uterine contractions, then what we are doing is we are essentially cutting off the blood flow to the tissue. So we have a compromised circulation in the endometrium. Then we get ischemia of those tissues, and that causes pain, right? Just like if you put a tourniquet on your arm and you compromise the circulation to your fingers, eventually they are going to hurt because they are going to become ischemic. All right, and if you leave it on there long enough, think about the baby who has an extra digit. If you compromise circulation for long enough, the tissue will fall off, right? Well, that's what happens when somebody has a period. We can compromise the blood flow to those tissues, the endometrium. It causes pain, it causes cramping, all from those uterine contractions. How do we manage dysmenorrhea? The big one is NSAIDs, right? So Motrin, analgesics such as Tylenol. Also, low-dose birth control pills will also help. Heat therapy, so heating pads, stress management. And if there's some type of organic cause identified as the cause of dysmenorrhea, so that would be a secondary type, right? You may have to have surgery to remove a fibroid or correct some endometrial scarring, those types of things. Moving on. Dysfunctional uterine bleeding, or DUB. Sorry guys, my clock is going off. All right, dysfunctional uterine bleeding is basically irregular bleeding. There are several types of DUB. I have them listed here for you. We have amenorrhea, which is no menstruation at all. And there are different types of that, primary, secondary, and physiologic secondary. We'll talk about them in detail in a minute. Oligomenorrhea is very scant bleeding. Menorrhagia is excessive or prolonged menstrual cycles. Metorrhagia is irregular bleeding in between your menstrual cycles. And then there's postmenopausal bleeding, which usually indicates cancer. So let's talk about each one of these. Primary amenorrhea is the absence of a period by age 16 or 14 if secondary sex characteristics fail to develop, like breasts and pubic hair. There could be structural abnormalities. It could be in relation to polycystic ovarian syndrome, hormonal imbalances, anorexia, bulimia, or excessive athletic training. All of those things can cause the hormones to be imbalanced when we're talking about anorexia, bulimia, and athletic training. And that will cause the absence of a period. So that's primary. Secondary is the absence of a period for 6 months in a previous menstruating girl. Usually we see secondary amenorrhea for individuals who have become anorexic or bulimic, who have started some really heavy athletic training, have lost a whole lot of weight. They have some type of hormonal imbalance or potentially ovarian tumors. So this is someone who has had a period, but now for some reason they are not having a period, and they have not had a period in at least 6 months. Secondary physiologic dysfunctional uterine bleeding is normal, okay? I'm sorry, guys. There are all kinds of sounds going off in here. All right, so secondary physiologic dysfunctional uterine bleeding is normal, and this is caused by things such as pregnancy, breastfeeding, or menopause. All of those things are normal reasons that a female would not have a cycle. All right, moving on. Oligomenorrhea is just a very scant bleeding, like we said before, and that's indicative of some type of hormonal imbalance. Menorrhagia is usually linked to thyroid disorders, endometriosis, pelvic inflammatory disease, some type of ovarian cysts, fibroids, clotting disorders, or people who are taking anticoagulation medications. And that is a concern, especially if the menses is repetitively long and heavy. So over and over, their periods are continually getting longer and heavier with every cycle, and they're on anticoagulation meds, they need to be seen, and maybe their meds need to be adjusted, or we need to do something so that they don't become anemic. Metorrhagia is usually caused from hormonal imbalances, pelvic inflammatory disease, uterine polyps, fibroids, or also cervical and uterine cancer can also cause these. And then postmenopausal bleeding are related to endometrial polyps, endometrial hyperplasia, or uterine cancer. The main one we think about there with postmenopausal bleeding is uterine cancer. So here is the etiology of amenorrhea. Remember, we have primary and secondary. Primary is the absence of a period by age 16. Secondary is the absence of a period for 6 months in previous menstruating girls. All right, so primary, structural abnormalities, genetics, hormonal, it can be PCOS, excessive physical activity, bulimia, or anorexia. Secondary can be related to hormones, ovarian tumors, excessive weight loss, excessive physical activity, or it can be normal, right, because of breastfeeding, pregnancy, or menopause. So what about for the other types? We've said a lot of these already. Menorrhagia, and postmenopausal etiologies. I'm going to let you guys read through those on your own. So what type of tests do we do to diagnose dysfunctional uterine bleeding? We can do ultrasounds, CTs, MRIs, a D&C, that is a dilatation and curettage, and that's where they go in and surgically scrape out the uterine lining. This is a correction for dysfunctional uterine bleeding, not necessarily a diagnostic test. You can collect tissue samples after this surgical procedure is done and then diagnostically test those tissues. But a D&C is an actual surgical procedure, okay? We can do endometrial biopsies. We can do different hormonal diagnostic testing. So we can draw blood and check the follicle-stimulating hormone, luteinizing hormone. We can draw CBCs and check for infection. We can look for thyroid problems, T3, T4, TSH levels. We can also do pelvic exams, pap smears, and cervical or vaginal cultures as well to look for infection or cancerous cells. So what are some nursing diagnoses related to dysfunctional uterine bleeding? Pain, knowledge deficit, ineffective coping, and sexual dysfunction are all examples of nursing diagnoses to consider. How do we manage this problem? Well, it depends on what the cause of the dysfunctional uterine bleeding is. If we identify a secondary cause, such as a fibroid cancer or infection, then we want to treat those things with possible surgery or with medications. We want to treat any kind of anemia that has occurred because of the dysfunctional uterine bleeding. We want to treat symptoms of anemia if the person has that. Help them with a high-iron diet is one way to do that. Progesterone and progestin are ways to manage it. Oral contraceptive pills, complementary alternative medicines, so diet, exercise, relaxation techniques, stress management, different types of herbal medications. Those are all different ways we can teach our patients to manage the different types of dysfunctional uterine bleeding depending on which type they have, and then surgery, like we talked about earlier. So, if we have to schedule somebody for surgical management of dysfunctional uterine bleeding, here are a few things that you might see. Hysterectomies are very common to correct dysfunctional uterine bleeding. The DNC, like we talked about a couple of slides ago. Endometrial ablation, hysterectomies. We can do partial hysterectomies or we can do total hysterectomies. They can also be done abdominally, which means we actually cut the abdomen open and take it out, or they can be done vaginally with the assistance of laparoscopic devices. The picture here is a uterine fibroid that was removed as a management for dysfunctional uterine bleeding. So this fibroid is huge, you can see, but it was causing a lot of pain and probably some bleeding for this person, so it was actually removed. A couple of things to note is that the partial hysterectomy removes only the uterus. A total hysterectomy removes the cervix as well as the uterus. And here is a picture of that. Okay, so we have a partial, and you can see there that it removes just the uterus. We leave the cervix and the fallopian tubes and the ovaries intact. We leave them there. That is good because if you're not a postmenopausal woman, those ovaries will continue to release hormones and prevent you, hopefully, from going in to early menopause. There is a total hysterectomy in which we actually remove the cervix along with the uterus, and you might find that for people who have some atypical cervical cells. Maybe there's some cancerous cells. And then there's also something called the radical hysterectomy, and that removes everything. That removes the fallopian tubes, the ovaries, the uterus, the cervix, and essentially the vagina. So how would we care for somebody going through hysterectomy? We got a couple of different time frames in which we start to educate these people, right? Before they have the surgery and afterwards. We want to do pre-op teaching as early as possible. We want to get their labs, chest x-rays, EKGs prior to them going to surgery. We want to give them an expected time that they will be up and out of bed, and that depends on the type of hysterectomy they have. Is it going to be abdominal or is it going to be laparoscopic? We want to teach them about diet and IV fluids. We want to make sure that they have a consent on file and that they understand the procedure that's going to happen. Prepare them by doing an abdominal shave. Let them know that we're going to be putting in a Foley catheter. And sometimes they have to have a bowel cleanse, but I think that's a little less common these days. Why do we put a Foley in before doing a hysterectomy? Well, if you think about the anatomy of people, it makes sense that if we are working in the general vicinity of the lower abdomen, we want to keep the bladder decompressed as possible. We do not want it filling up with urine, because then what happens and what is there a risk for? There's a risk that we can nick the bladder and cause some pretty big issues. So we put a Foley in to keep the bladder deflated. Post-operatively, we want to focus on prevention of complications. We want to prevent DVTs. We want to prevent pneumonia. We want to collect vital signs and pain scales. We want to talk about pain management and the different types of medications we can use to help this person manage pain. We want to look at IV hydration and nutrition. I's and O's are very important to keep up with. Looking at the wound, doing assessment on those puncture wounds for laparoscopic procedures, or on the incision if it's an abdominal one. We want to teach the patient how to care for those sites. We want to give them appropriate discharge instructions, especially for people who have had the laparoscopic hysterectomies. Those can be done with the robot these days, and these people stay for 23 hours. They are admitted under an observation status. They do not spend a lot of time in the hospital, so it's very important for us to do good discharge teaching with these individuals. So what are some types of complications we might see? Well, we might see DVTs. We might see a paralytic ileus, and that just means that the ileus is paralyzed, right? We have a bowel that just stops working because we've handled those organs. You might see hemorrhage, wound infections, urinary retention due to damage to the bladder during the surgery. Pulmonary embolism is a possibility. Surgical menopause, especially if we have taken out the ovaries. And these women might have issues of femininity and sexuality, especially if we've removed the ovaries. But even if we don't, these women still may go through a small period of depression and have kind of a real psychological component to this surgery because we've essentially removed their womanhood. So those are things to keep in mind. So what do we expect? We want the client to be relieved from any kind of discomfort and pain. We want them to report a reduction in their anxiety level. We want them to be satisfied with sexual activity and other forms of sexual expression. And we want them to experience no complications from their surgery. Think about some types of nursing diagnoses that these people might experience: situational low self-esteem, acute pain, sexual dysfunction, impaired urinary elimination. All are a few nursing diagnoses that you would see associated with this type of procedure. Okay, let's run through menopause, see how quickly we can do this, and this will be the end of lecture 1. All right, so what is menopause? Well, menopause is a normal physiological process, and it usually lasts several years. It is the permanent cessation of menses as a result of reduced ovarian activity. Okay, estrogen and progesterone production are greatly reduced. Follicle-stimulating hormone and luteinizing hormone are very high. Okay, so this happens sometimes around 48 to 55 years of age. These people during this time become perimenopausal or climacteric. There is an increase or a decrease or an irregular menses until it completely stops. So this is a time when the reproductive function gradually decreases and stops. We have a postmenopausal period, which is 1 year post cessation of menses. So that means that you are not postmenopausal until you have not had a period for at least 1 year. There's surgical menopause, which means after an oophorectomy. That's the removal of the ovaries. And then there is chemical menopause. This would happen, you might see this for someone who has had some type of chemotherapy and their ovaries are destroyed essentially from that medication. What happens in menopause? Well, we got to assess signs and symptoms, and some of us know in general what those are. You've heard people talk about them. These people have vasomotor instability. So they have hot flashes, palpitations, dizziness, headaches. They experience night sweats and insomnia. They are at risk for osteoporosis, cardiovascular disease. They have high cholesterol, some of them. They have big changes in their internal reproductive organs. So the cervix, the ovaries, the uterus, even the urethra and the vagina will actually atrophy and reduce in size. Things just aren't what they used to be. They kind of shrivel up. There's an increase in pH also, and this can equal a greater risk for vaginal and bladder infections. These people are irritable, they're anxious, they may be depressed, they may experience more headaches, moody, have an inability to concentrate. And if you compare these symptoms and signs, many of them sort of mirror PMS. So here they are, the 7 menopausal dwarfs. Itchiness happens because estrogen stimulates the formation of skin-smoothing collagen and oils, and during menopause, estrogen greatly decreases. So if that happens, then the skin can become itchy and very dry. These people have mood swings. They may become very bloated, and that's because of an increase in sodium retention because of fluctuating estrogen levels. They may be very sleepy due to insomnia, and it might be due to the fact that it's because they're having night sweats, so they can't sleep. So what are some nursing diagnoses to consider with people who are going through menopause? Altered comfort, for sure. Knowledge deficit, disturbed body image, altered sexuality patterns, risk for bone fracture and heart disease. Consider those and consider why this particular type of menstrual dysfunction would cause you to come up with those nursing diagnoses. How do we help these people manage? Well, there is hormonal management or hormonal medications, but that's controversial. Long-term hormonal treatment can cause breast cancer, ovarian cancer. It can cause strokes, heart attacks, blood clots, pulmonary embolism. So we try to avoid using a hormonal management like estrogen replacement for long-term periods because of the great number of risks associated with it. But there are also lots of non-hormonal management tips that we teach. Loose clothing, no caffeine, no alcohol, exercise to increase that HDL type of cholesterol, vitamin E for the skin to help with itchiness, sleep hygiene. It has also been found in clinical trials that hormone replacement therapy is not cardioprotective, meaning it does not help you cardiac-wise. And that's because it increases the risk of strokes, heart attacks, blood clots. So just take note of that. So this is a few types of estrogen preparations that you might find patients on. This is hormone replacement therapy. Premarin is a conjugated estrogen. Provera is also an estrogen preparation, but that contains progesterone. The conjugated estrogen, such as Premarin, is just a mixture of several different types of estrogens. And then there are also selective estrogen receptor modulators. An example of those would be something like Avista or tamoxifen, and those help to prevent bone loss. And tamoxifen is actually a chemo drug as well. It helps prevent breast cancer. But remember, the danger of using these for prolonged periods of time actually increase greatly the risks for things like cancer, stroke, heart attack, blood clots, pulmonary embolisms. All right. A couple of more slides. Nutritional therapy, this is another way we can help these people. They need to get lots of calcium. They can take antacids like Tums and those kind of calcium chews just to help get that additional intake of calcium, because they're at a great risk for osteoporosis. We also know calcium doesn't work without vitamin D, so these individuals need to be taking in a sufficient level of vitamin D or taking a supplement. Phosphorus also works along with vitamin D and calcium as well. We want them to eat estrogenic foods, and that will help them to prevent vaginal dryness and other issues. So note this chart here at the bottom of this slide, and this will explain to you some different types of estrogen-rich foods. There are also alternative and complementary alternative ways to help with menopause. Acupuncture is one that's being used these days, massage, biofeedback. Biofeedback are breathing techniques that you can teach your patient to help control things like hot flashes or anxiety. Soy protein is also very high in estrogen. Meditation and yoga and ginseng has been proven to help with insomnia for those patients who are having trouble sleeping. What do we expect? We want this client to be relieved of vasomotor instability symptoms as much as possible. We're not going to relieve everybody's hot flashes or all of their night sweats, but we want to teach them ways to at least relieve them to reduce those symptoms. We want them to verbalize an understanding of the structural and physiological changes that are going to happen as a result of their aging. We want them to be able to cope with the strategies to be able to reduce anxiety. We want them to be able to sleep well, at least 6 hours a night. And we want them to adopt healthy lifestyle behaviors to prevent the issues that come along with aging and menopause, such as osteoporosis and cardiovascular disease. Okay, so that was all of our talk on menstrual disorders and the female internal reproductive cycle and hormones associated with that. So this is the end of Individual Module 5.1, PowerPoint 1, Lecture 1. Tune in to the next lecture, and we will continue talking about antepartum. Thanks for listening.